I want to start out by saying that although I've been working in this field for the past 10 years, I learn something new every day. And from my knowledgeable colleagues and mentors like Robin, and more importantly, from healthcare providers and patients and family partners that I work with. I can't underplay how important they are in the work that I do. So we should probably start off at the beginning with a definition of implementation science. So I've taken this one from a paper from Bauer et al., who directed their work to folks who don't necessarily work in the space of implementation science. So the definition that they propose is this: the implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and therefore to improve the quality and effectiveness of health services. So early in my career, I had the privilege of meeting and working a little bit with Martin Eccles, who was the founding member of the founding editor of the Implementation Science Journal. He was reported to say that most people use the Islasliad principle to guide the design and evaluation of interventions or implementation strategies. And what that principle is basically, it seemed like a good idea at the time. So as you can tell from this, Martin is a strong proponent of using a systematic approach and theories to strengthen our KT interventions. So I want to share a simple analogy on the topic that some of you might be able to relate to. I was inspired to use a baking analogy as a result of my renewed interest in trying new recipes and cooking while hanging out in my bubble over the past 9 months. Some of you may have done something similar. I want to say that in addition to baking, I've also built a COVID garden and started building simple wood furniture, but I think that I'm going to stick to baking for this and my cooking journey for this analogy. So if you think about baking a cake, the ingredients or components that you use will certainly influence your end product. You can't leave something out or easily substitute ingredients and expect to get the same result. So planning and assessing in this context, or looking at your resources, is really important. Just as important is the process we use to put those ingredients together. So the order in which you add them and the length of time and the temperature you use to bake them all will impact your end outcome. And if you try baking in somebody else's kitchen with their ingredients and their tools, or such as their oven or their pans, you'll notice that your outcome will likely be slightly different. And if you've ever watched the Great British Baking Show, which I absolutely love, you'll notice that, those who are experts but use different kitchens and are under time pressures can often create disasters. So those factors can also influence the outcomes. And further, if you haven't taken into consideration your end users, those who eat your cake, the uptake may be less than optimal. So those who, for example, have gluten intolerances or lactose intolerance or friends with diabetes may be unlikely to, engage in your beautiful chocolate cake. So I saw that there were many analogies here to implementation science. So let's begin by getting some of the terminology out of the way. And anyone who works in this space will likely agree that there's a lot of discussion, confusion, debate in the literature about these terms. But for simplicity's sake, perhaps we can agree that a theory is an explanation for an observation. It's based on a hypothesis or assumptions about how something works. And this is really important when we think about, go back to our cake analogy, when you put these components together, you have a theory in your mind about how your product will turn out. A framework is a list of a basic structure or components that are part of a system or a concept. And a model is the representation of a system or a concept with specified assumptions. So why is theory important? If we think about all of the reasons why we should be using theory and implementation science, this just scratches the surface. So this idea of making your assumptions explicit is really important. So how these components go together can influence or make explicit to others how you think your intervention is going to work, how your cake is going to turn out. Using theory also helps us with measurement. So it allows you to measure, if you are explicit up front with how you think your intervention is going to work and how the components are going to work together, then you can measure each of those components separately at the end. It allows us to, or makes it easier for us to interpret our results if we're explicit up front about our theory. It improves intervention design by linking targets with intervention components. It improves the generalizability of our findings. It promotes knowledge synthesis. So it allows us to pool evidence together so that we can build the scientific field or contribute to the scientific field. It promotes replication. So if you use a particular theory in a particular way, you make that explicit to guide the design of an intervention, somebody else can pick that up and replicate that study. So if you're explicit about what you're doing and what your assumptions are, then it allows another researcher or another clinician to replicate your work. And it also helps with building or testing theories if we are, again, explicit about using theories to underpin our work. So these are just some examples about why it is important for us to use theory to build the scientific knowledge base about implementation science. So some work was done in 2018 by some colleagues of mine who conducted a scoping review to identify the significant number of knowledge translation theories, models, and frameworks that have been used. And the search was undertaken between 2000 and 2016, and they identified 159 KT theories, models, and frameworks. So there's a wide variety of frameworks that are being used, but what they did also identify was 87% of them were used in less than 5 studies. So this idea of replication and building on each other's knowledge, that if everybody's using something unique and something novel, it's difficult to build knowledge in the field. And in the context of this scoping review, 60% of those models or frameworks were only used once. Most were used, interestingly enough, to inform the planning or the design, implementation, and evaluation activities, and less commonly used to inform dissemination and sustainability or scalability activities. All targeted at the individual, all were targeted at individual level of change. 48% were targeted at organizational level change. 33% were targeted at community level change, and 17% at systems. So this identifies some potential gaps in some areas that we need to work on in terms of building the science of knowledge translation. A number of implementation scientists have examined the use of theory in designing health interventions, such as self-management interventions for skin care in people with spinal cord injury. And they've identified a lack of theory underpinning such interventions, as well as the limited scope of theories when they were used. So this sort of builds on the findings from the previous scoping review. Our team has also completed a narrative synthesis of discharge communication literature and identified similar findings on the topic of pediatric emergency practice environments. The use of discharge communication in this context has largely been oversimplified in the literature, with a corresponding atheoretical approach to designing our interventions. And for the most part, ignoring the context of where the discharge communication takes place in a busy emergency department, a noisy emergency department, and where the information communicated is used. And in the context of emergency practice environments, that information is often used at home. So we did find that many of the theories and interventions that were used failed to take into account these particular components. So if we were inclined to use theories and models and frameworks in our work, where do we start? How do we choose? So some points that you might want to consider in making your choice is to first of all think about what level that you are targeting in terms of an intervention that you might be designing or a program that you might be implementing. So are you looking to design at the end or to target at the individual level, at a team level, at the organization level, or at the system level? So those are things you might want to consider. You also want to consider what stage you're addressing. So is your work related to planning an intervention? Or are you actually conducting some work or evaluating, or is your interest in evaluating an intervention or outcomes? So that may choose what theory or frameworks you use. What is your aim, or what do you need to understand? What kind of resources will you have at your disposal? And then what has been used in similar scenarios to address similar problems? So you might want to look back in the literature and see if there's anything that has been used already in the area that you're interested in working in, and perhaps you could build on that or address gaps that the research might have identified. So in general, there are 3 aims for using theories, models, and frameworks. And they are to describe or guide the process of translating research into practice, to understand or explain what influences implementation outcomes, and to evaluate implementation. So those are the 3 broad areas or aims for using theories. Nielsen et al. Has published a paper in 2015 helping us to think about how we might categorize theories and frameworks. So broadly speaking, they group them into 3 areas, which I just described, and talked about at a lower level how you might categorize those. So if you were interested in describing or guiding the process of translation, you should probably be thinking about process models. And if you're interested in understanding what influences implementation, then you might be leaning more towards looking at determinate frameworks or classic theories or implementation theories. And if you are specifically interested in evaluating implementation outcomes, then you would probably be looking more towards evaluation frameworks. So I prepared a few slides to talk about each of these 5 categories. And I'm only scratching the surface. I just want to say that, there are, as was pointed out, over 150 theories or frameworks that could be used. So I clearly don't have time to cover them all. But if we think about related to process, many of the theories and frameworks that are in this area are related to planned action theories. So this idea of starting with identifying a problem and moving right through to disseminating your results. And probably one of the most classic ones in Canada that most people are familiar with is the knowledge to action framework, which starts with the central core or the knowledge creation funnel, in which you have aggregate information, and that begins the process, and then moves to this identification of problem. And you can see with the arrows moving back and forth, it indicates that there's a feedback loop. So this is a constantly moving iterative process or cycle where you move from problem identification to through to knowledge use, evaluating your outcomes, and then the model starts again. But you can always go back and forth between those sections or stages of the cycle. So moving along to determinate frameworks. These describe general types of factors that are hypothesized or have been found to influence implementation outcomes. So, for example, if you were interested in looking at adherence to clinical practice guidelines, these frameworks help you to, characterize what types of what types of factors might influence behavior. They don't discuss how change takes place, nor do they describe any causal mechanisms. They're generally similar in terms of the types of determinants or factors that can influence implementation. So things like characteristics of the interventions themselves, the adopters or the intervention users, the end users, the context in which the phenomena is being studied, and the outcomes that you're interested in. So perhaps two of the most common ones that I can talk about in this determinants framework is first of all the Parish model, or the Promoting Action on Research Implementation in Health Services framework. And the three main sort of sections in this framework are, first of all, the interplay between these core elements of the nature of the evidence, the context or the environment in which the research is to be placed, and then this idea of the importance of facilitation, or the method used to help, or the process used to help move the information forward. Another framework that is common in this structure of determinants is the CFR, or Consolidated Framework for Implementation Research. And this is an explanatory framework that has 5 domains. So intervention characteristics, the outer setting and the inner setting, and then the characteristics of the individuals and processes. It shows you that there are only 5 major domains. It's actually a very complex framework that has 39 underlying constructs and sub-constructs. And they can be used to, raise awareness for potential influencing factors. They can facilitate the analysis of important process and outcomes, and it can help organize all findings of an implementation process to explain the outcomes. So as I'm describing these particular frameworks or theories as we go forward, I want to point out that they're not all necessarily just situated in determinants. Some of these frameworks can be used across the different purposes or types. So then that classic theories, and one such example are those related to social cognitive theories, and they've primarily been used to examine determinants of health-related behaviors of individuals. They're often explanatory, or they are explanatory in nature. And there's a broad categories related to social cognitive theories related to motivation, action, and stages of change. So one such theory is the social cognitive theory, which describes the influence of individual experiences, the actions of others, and the environmental factors on individual health behaviors. So then moving on to implementation theories, one such theory is the behavior change wheel, which was developed by Susan Meeke et al. And it is a synthesis of 19 behavior change frameworks, and it draws on a range of disciplines and approaches. And so you can see with this diagram that it has a number of intersecting sections. The inner core, or the green core, is related to the COM-B core of the framework, which implies that behavior is a factor of capabilities, opportunities, and motivation. So I'm not going to spend a lot of time thinking about this, but I will describe to you when I'm showing you examples of how I've used the behavior change wheel and the COM-B to design and evaluate some of my behavior change interventions. Another such example of a framework that might be used for implementation is the theoretical domains framework. And this is, again, a synthesis of 128 constructs from 33 different behavior change theories. So unlike the second component, which we talked about, which is the different type of theories, this framework actually is a compilation of 33 change theories, and it has 14 different domains that could be useful in identifying factors, again, that influence implementation. And then finally, the fifth category of the types of models and frameworks that you might be interested in are those that might be used to evaluate implementation. And so those are implementation or evaluation frameworks. And this is one such example, the RE-AIM framework, which was developed more than 2 decades ago, and is probably one of the most frequently used frameworks. The main goal from the beginning of its inception was to improve assessment and reporting of 5 domains of research. So on the right-hand side of this slide, you can see what those each of the RE-AIM letters stand for. So the dimensions of R, or research, are the number of individuals who are willing to participate in research. The E, or effectiveness, is the impact of the intervention on important outcomes. A, or the adoption, is the number of settings and intervention deliverers who are willing to initiate a program. I, or implementation, is looking at measuring the fidelity of the intervention, or was the intervention delivered as was intended. And finally, M, or maintenance, is the extent to which the intervention is sustained past 6 months. So you can see how each of those components or each of those domains are important to understanding the impact of your intervention. So a lot of the work that I have done in terms of using theory has been mostly focused on using to design and evaluate interventions. So theories can be useful to identify those critical behavioral determinants or those targets that you might want to focus on when you're developing your behavior change interventions. Theories can be used to link appropriate behavior change interventions with targets. So you can see how that could help build, improve your evaluation and begin to build science in the field if you have those linkages that you can test. A lack of clear theoretical underpinnings limits the potential for understanding effectiveness of the intervention. And more importantly, interventions to change complex behaviors will need to draw on concepts from multiple theories. So in much of the work that I'm doing, I do use not one theory, but a number of theories and a number of frameworks at different stages. So one such example of the work that I have done that has incorporated different theories is the work that I'm doing around co-designing discharge communication interventions. And in this work, I am actually working with healthcare providers, so those actors that work in emergency departments, and patients and families, those actors that use the emergency department, to build an intervention to improve discharge communication. So some of the different theories and frameworks that I'm using are the behavior change wheel, which has guided the process of the intervention design. I'm using the theoretical domains framework to help understand what some of the barriers for discharge communication are. I'm using the capability, opportunity, and motivation model to help me understand what are those key factors that we should be addressing. And I'm using the patient and public involvement frameworks to support my co-design process. So this idea of working with my knowledge users, healthcare providers, and patients and families to help contribute to that design process. One other project that I'll share with you is the work that we're doing that's been funded by a Translating Research into Care grant, or a TRIC grant, is evaluating an electronic patient managed discharge communication tool. And up to this point, you've heard me say that patients and families haven't been involved in designing discharge communication tools, nor have healthcare providers. But from our perspective and messages that we've received from patients and families is that many of the tools that have been developed thus far have focused on topics or information components that they are not really interested in or are not of importance to them, and language that is used, that has been used in these tools, has not been accessible to them. So what we did in terms of developing this electronic patient managed discharge communication tool was work with patients' families who said that they wanted to document their own discharge communication and have it validated by healthcare providers that they're working with, so that when they take these tools home, remember I had said earlier that they had indicated, or the literature indicated, that they hadn't taken into consideration that the tools that were being developed were actually being used by the patients and families at home. But this is a tool that they will design themselves using words and terms that are of importance to them and are familiar to them and make sense to them. And they will validate the information that they capture during the discharge, during the emergency department experience, validate it with their healthcare provider before they leave to make sure that it's accurate. And then they will have a tool at home that makes sense to them. So we're in the process of evaluating this, and we are using, again, the COMBI model to help us evaluate those components of impact. So in conclusion, I want you to remember that interventions that are poorly designed and evidence-based practices that are poorly implemented or not implemented at all do not produce expected health benefits. Thank you, and that's all I have to share.
Thank you so much, Janet, for that presentation. You have a talent to be breaking down those frameworks and making them more simplified for us, so I appreciate that. We do have some questions that are coming up, and while Robin gets started, Robin, you'll have the ability to share your screen now. Perhaps we can just touch on the first one and then save the second one until after Robin's presentation. So Jamie asks, what is usually considered evidence in implementation science? It seems difficult to do prospective studies comparing which theories are more effective. Janet, do you have anything to say to that? You can also read it in the chat if you need to read it again.
So which theories are more effective? Well, you know, I can tell you that there is not, you know, an overwhelming body of evidence that says use this theory if you are trying to achieve this outcome necessarily. We're provided with some indicators that help us. As I pointed out, there are categories that we can use to help guide which theory might be useful in particular situations. But until people start using theory to pull, we have some indicators, again, is in a given scenario, because it really depends on the context and it depends on the purpose. I'm not sure if that's helpful, but there is a growing body of evidence, and as we use theory more often, and we can help contribute to developing that body of evidence.
Thank you, Janet. I'm going to give the stage over to Robin, and Robin, you can answer that question before you get started if you have anything else to say, or we can dive in.
No, I think Janet answered it beautifully. There is no, I've certainly, I mean, there's a growing body of evidence about why you might use certain theories in certain contexts, but I would say there's no, just as Janet said, no one best theory. And I would say that I mean, I really liked what Janet said a minute ago, because I operate the same way in my work, that I often use multiple theories in the same study, depending on sort of at different phases, different stages, and depending on the purpose. So. Okay, I'll start. So I'm going to take us in a bit of a different direction, and talk about practice. So I do come at this. I mean, I am a researcher and an academic, and I have a program of research in implementation science. But I'm going to talk a little bit from the flip side today, I guess, in terms of trying to implement things, you know, in the real world. So some objectives, I really want to sort of get across this idea that there are there are social and cultural parts of implementation, and I think you'll see what I mean as I go through this. I want to talk about some key findings from sort of, I suppose, from my research here in Nova Scotia over the past 15 years, where I've studied sort of the implementation, both sort of retrospectively, so looked back, and prospectively, studied the implementation of a whole lot of different tools, technologies, cancer therapies, and so on. And then share an example that really, I'm going to say, illustrates some of the messiness of implementation. So I just put this up here. I mean, I think this is sort of the challenge, right? Is that research, and not just research, other sort of evaluation activities and so on, is consistently sort of producing findings that can contribute to more effective and more efficient patient care. But the reality is those findings aren't going to do anything unless healthcare providers and organizations and systems actually use them. So I think that's sort of the big challenge that we're talking about. And there is quite a bit of, I suppose, an evidence-based research. These citations are a little old right now, but essentially that the critical issues concerning sort of health system improvement and health improvement, and getting evidence-based practices into sort of care and policy relate less to the dissemination of evidence, so less to the sharing of evidence, and much more to its implementation. So implementation really is action, right? It's characterized by action, and sort of some of the places where things fall down often isn't around, you know what, making the decision to say, you know what, we're going to do this. This is something that's important, and let's start thinking about it. It's actually getting things done. And I'm very happy to see what Janet had on her last slide, because this is one of the big points that I want to stress as well, is that implementation is a known determinant of effectiveness. So you need an effective intervention, so something that's been shown to work, right? But you also need successful implementation if you're going to get the desired outcome. So you can have the best intervention in the world. If it's actually not successfully implemented, you know, if people don't use it, they don't use it consistently, they don't use it appropriately, then you're not going to get your desired results. So I'm putting this up. I stumbled across this paper when I was doing my PhD, actually. So it's a 2005 paper out of JAMA. And essentially, this paper is all around why the majority of large IT projects in healthcare fail. And when I stumbled across this, it really became a light bulb moment for me, because everything that I was seeing in my own data, so I was studying for my PhD the implementation of an electronic tool, synoptic reporting tools, an electronic tool in various different programs and services in the cancer system. And what was being written in this paper, I guess, was sort of just like a light bulb moment, because it was everything that I was seeing in the data that I had. And really what this paper argues is that the misleading theory about technology is that technical problems require technical solutions. So we often think of any sort of issue or problem that we have, I think, in a very sort of rational way, and we think, you know, we come up with these technical solutions. But if you think about it, all organizations, certainly healthcare organizations, but all organizations are really at the same time social and they're technical. So by social, I mean, you know, they're composed of people and values and norms and cultures. and they're technical. So, we have tools, we have equipment, we have facilities, we have procedures, and that's what sort of allows people to do their work, right? And I guess without those things, the organization wouldn't even exist. So at the same time, we have both of these sort of components. And so this paper was specifically around large IT projects, but essentially the authors argued that good design or good implementation is not a technical problem, but it's one where we really have to optimize both the social aspects and the technical aspects. So I'm going to tell you a story from Nova Scotia, and this is from my own work. So a project I've been working on in phases over a number of years. And I just sort of highlights the messiness again of implementation. So just by way of context, so back in 2011, what was then Capital District Health Authority, so it's really central zone here now in Nova Scotia Health, did a needs assessment of interprofessional frontline staff. And what they found in that needs assessment is that staff said that dementia care, and this was staff in acute care, on acute care units. And they said that dementia care and managing responsive behaviors was really their greatest frontline challenge. And it was the #1 area for desired education and training. So just responsive behaviors, just to have some context here, it's just sort of the actions, words, and gestures of somebody who has dementia or delirium, which are a response to something that's important to them. So really put another way, the way I think about it is that it is the person's attempt to communicate some unmet need. So they need something and they're maybe unable to communicate that as you or I can without dementia. So, but they're trying to communicate a need that they have. And that can be needing to go to the bathroom, being cold, maybe they're hungry or thirsty, they have pain, there's sensory overload. So any of those things. And we also know that more than half of all acute care hospital beds in Canada are occupied by older adults. We know that impaired cognition is common in acute care. So you can see there sort of the rates that some of the research has shown in terms of experiencing delirium and dementia. But what we also know is that there are evidence-based practices to manage those responsive behaviors. And really what it comes down to is figuring out what's causing the behavior, so what that unmet need is, and then making a care plan to address those reasons, whatever it is. So that might be trying to sort of reduce like stimuli in the person's room, like in the environment. It might be making sure that the patient has sort of regularly scheduled bathroom breaks, if that's what it is. But there are evidence-based sort of ways to manage these behaviors. So what we did is we wanted to build, based on that needs assessment, we wanted to build capacity in frontline staff in terms of managing these responsive behaviors in older adults who have dementia or delirium in acute care. So we did a pilot project really to develop an intervention. And what we did was, again, this was theory-based, and what we did was we held a series of focus groups across a number of acute care units in Capital Health at the time to really understand staff's sort of learning needs and preferences around this issue, but also sort of the barriers and the challenges they face with respect to managing these behaviors in acute care and caring for these people, these individuals. So from this project, what we did was we developed an intervention, then we evaluated it. We put that intervention in place on a couple of acute care units, and then sort of refined it after. But essentially, the intervention was, largely educational in nature, although more than that. But it was really to be able to put these sort of evidence-based practices into care, into practice. So the final intervention that we tested more broadly and looked at different measures and outcomes, really it was in-person training of interprofessional care team members. So nursing staff, physiotherapists, occupational therapists, unit aides, personal support workers, and so on these units. And in that was led by a person with expertise, a clinical nurse specialist with expertise in geriatric medicine, And there was a number of components of that, but I mean, there were videotaped clinical scenarios. It was a group exercise to develop a care plan and so on. Then we also had what was essentially a toolkit placed on each unit. So it was a physical toolkit for each of the, or we built a toolkit for each of the units that had a lot of like practical guidance. So like list of medications to avoid, for example, point of care tools, so behavior tracking forms, so different things to help implement this into this sort of these evidence-based practices, teaching material for families. And there was an online resource as well with the toolkit. So the toolkit was online as well. So then we applied for a translating research into care grant to really assess the impact of that intervention and to understand how the intervention was implemented. So from this TRIC grant, we then found 5 acute care units in what's now Central Zone. 2 were in the community and 3 were tertiary. And these units expressed they wanted to be involved. They heard about the study happening and they actually came to us and said, we want to be a part of this. So I'm not going through the methods here at all, but there was a whole bunch of quantitative and qualitative measures that we looked at. I underlined goal attainment because that was actually our primary outcome, was sort of individual clinicians, staff members' goal attainment with respect to the care they're providing. But we looked at use of the intervention, use of certain medications on those units and in sort of the population of interest. So things like benzodiazepines and so on, which really for the most part are not indicated for older adults with dementia or delirium. We looked at things like use of sitters. So I'm explaining this just because when I show the next slide and results, but really that's just a sitter is a care attendant who comes into the acute care unit from an outside agency who provides constant like one-to-one observation of a patient. And so we had, among others, we had a whole bunch of things that we were assessing actually. So, we got this grant and it was fantastic. And I'm just pointing out a few things that we thought, we did right. And I mean, I think we did do right, fist pump here. But, we addressed a high priority concern of clinicians in our zone. This was their number one concern from our earlier needs assessment. We had evidence-based practices. The intervention was theory-based and informed directly by the staff themselves. It was a co-design project between the researcher, who was me, clinicians, and a health system decision maker. And to be honest, I don't even know if I can say co-designed. Like I did the methods part of it. Like I wrote out, I sort of my expertise that I brought in was obviously methodological, but really this was led by the clinicians themselves. And had a theory-based evaluation. And so I won't get into it, but a number of the theories Janet just talked about were used in this work. And then real life happened. So what did we find? Very high level. I'm not getting into all of it here, just a few things. One was that the uptake of the intervention varied across the units, particularly sort of that in-service or that in-person. So some units had very high uptake from staff. So we ran these in-services, they're called, a number of times on each unit, participating unit. And then during interviews that we did at the end of the study, really we found that the reason this uptake varied, so on some units we had low uptake, and that was related to sort of staffing, as it was sort of identified as the main reason. And by that I mean staff were just too busy, felt they were too busy to leave the unit to attend training. And again, we had multiple trainings on each unit, but weren't permitted. They weren't allowed to actually go. Where's the staff? Yeah, this one. So staff, I'm going to get it back to this. So again, the messiness of the real world. Staff were largely inaccessible for our post-intervention, some of the post-intervention outcomes. Now, some of them just came from hospital databases and so on, but our primary outcome couldn't be assessed, and I'll get at that. Most outcomes were not impacted by the intervention. Those that we did see, so we did time series analysis, but those that were impacted, the improvements were not sustained. So for example, we saw on the units that sitter cost decreased in the 3 to 4 months post-intervention. We saw a clear decrease, but after that, just completely returned to pre-intervention levels. So when we did our qualitative work, just a couple of things that we found, again, sort of efforts on each unit to support intervention use were rather minimal. And the barriers to sort of implementing these evidence-based practices, really included high staff turnaround. So again, as I just said, I'd talk about this, but most of the people, the participants in this study who are staff members, most of those who did the training and had that and were introduced to the toolkit and things like that, left the unit shortly thereafter. So when we went back to do qualitative work and to do the goal attainment scale and so on, 6 to 8 months later, most of those people were not on the unit anymore. Limited time, people talked about limited time to actually do the interventions themselves, like the evidence-based practices. So things like behavior tracking and actually creating care plans for patients. And limited support from unit managers to undertake these activities like behavior tracking, creating care plans, and so on. So the key takeaways here, and when I say care plans, I mean specific to managing these responsive behaviors, not care planning for other reasons. And so what our key takeaways as a team really was that support of the unit manager is absolutely critical. So staff really who took part in this really described, not a lot of incentive to engage in sort of those activities, in those practices, if it wasn't expected by their managers and supported by their managers. This is a culture change issue. So acute care staff are concerned really with acute care issues. So caring for older adults on these acute care units who have dementia and delirium is not always the priority, I suppose. And staff turnover is a real concern. As I said, most of the people who started in this study were not on their acute care units within 8 months. And so I think this highlights, again, the messiness of trying to then do this in the real world, but it highlights the need for ongoing training and skills development and so on in our organizations. I think this is going to be really important as many of our sort of organizations and hospitals and so on are making that move or trying to make the move to learning health systems. So some people on here will be sort of familiar with that term, but sort of as we try to go there, I think this is a component that's going to be really important. Okay, so just sort of some high-level takeaways, and then we can open it up for questions. So I've been here in Nova Scotia studying sort of implementation for about 15 years or so now. And I've done it in a number of ways. So I've done a lot of qualitative and mixed methods work to study the implementation of new technologies, new practices here in Nova Scotia. And that sort of ranges from, new sort of practices in diagnostic imaging, in cancer surgery, pathology, radiation therapy, supportive care, and so on. So I've done a lot of work there. And, I don't want to be all doom and gloom. So what I've found over the years, right? I mean, some implementation initiatives and projects have been quite successful, some not so successful. But I would say that rarely was any project linear. So, and by that, I mean, went entirely according to plan. So stuff happens, right? And there's a messiness of all of this that certainly comes up time and time again. But I'm just going to talk for a few minutes about some of the sort of things that I found, the key high level findings from all of this work. And I think that those of you that are on here who are clinicians or who are like managers and so on certainly get this. The first is sort of stakeholder engagement early on, and how important that is to enable implementation, and how important it is, if not done, to sort of hinder and to impede implementation. So leaving out the people who will be sort of using the new tools and systems or whatever it is really, I would say, is a grave error that will almost always lead to resistance or lead to some challenges. And I always tell people when I work, so I mean, I'm a scientist, but I also work with a lot of teams in the health system, sort of doing implementation projects. And I always tell people one of the first questions you should ask is, who will be impacted by the change that you're trying to do, and who can impact it? So those are can be two different groups of people. There's certainly an overlap, but who will be impacted and who can impact it? And what I have found, certainly in my research, and this would be in the literature as well, is that if these people are not engaged early on, both sets, again, you can encounter resistance. I would say that everything that I have studied for the most part in Nova Scotia in terms of implementation has required champions. Most of the time, this really is clinical frontline champions that drive projects. Sometimes they're managers, sometimes administrators, for sure. But you do need somebody driving it. And again, from a practice standpoint, one of the things that I've seen in my work is that there are risks to that as well. Relying on champions, because these folks often are doing this off the side of their desk. And so they're not being adequately supported to take on that champion role. And you know what? A lot of times they burn out and they leave the organization or they retire. And so there's some risk there, I think. Middle manager support is key. I've actually done quite a bit of work around the role of middle managers in implementation in healthcare. And they are, they are incredible enablers to sort of implementation. Also, though, again, if there's a lack of understanding why something is happening, or if they're not engaged early on, or if they don't have the resources or whatever, the capacity to do it, it can hurt implementation. Multiple sources of evidence. I think this is really important. Certainly important, I think, when I think about myself as a researcher. So, sitting sort of outside, I guess, the health system and as an academic. So it's not just research evidence that's important. So a lot of people who are making decisions about implementation and people who are the implementation teams themselves, there are other sources of evidence that they seek out and really need. And one of those is sort of simply put, just information from other jurisdictions. So it's not about the scientific evidence. It's about, okay, so other places, let's say Ontario or BC or wherever, right, has implemented this already. They want evidence, they want information from those places to know, okay, so, what was the real world impact of doing this? What were the implications of doing this? What's the operational implications, the budgetary implications, whatever. But also sort of the implementation advice, because often in a research study or a systematic review or a whatever of some sort of intervention, you get information about the effectiveness of the intervention. You don't necessarily get information about how to implement it. And so that's very valuable evidence that people really want. Adaptation, I won't say a whole lot here. As an implementation scientist, I think there's always this, oh goodness, what's the word? Tension between fidelity and adaptation. But I would say implementation, there is little to no implementation without some level of adaptation. Ongoing training and education. I mean, I just spoke about, I highlighted the need for that in my example earlier around sort of, we just can't do it one time, people leave the organization, people leave the setting and so on. And then relationships, and I mean personal relationships and organizational relationships and how important these are. So I've studied initiatives where relationships were incredibly strong, and maybe the initiative was lacking in some other areas like resources or some infrastructure, but like people could get things done when the relationships were there. I've also studied initiatives where relationships were weak, maybe not non-existent, maybe poor, maybe there's a strained relationship. And even with everything else in place, it can be really, really difficult to move things along in that sort of context. Here's just a couple of quotes that came from, folks in Nova Scotia here over the years from some of my work talking about sort of relationships. So both at the departmental level, you know, there is also personalities. Unfortunately, the environment wasn't really conducive for change, but also at the organizational level. So this other person says organizational interactions are absolutely the #1 factor, and was referring to the reason why something, the implementation of an IT technology took so long was not to do with anything technical. It was sort of the history between organizations and the interactions between them. So I guess my point was in this talk, I'm just about done, was to sort of make this point that, you know, rarely in real life, or rarely is real life as rational and structured as we often assume it to be, or often want it to be, right? And so that's a bit of my point. So I think right here, I've got this big thing up, and I sort of want to get to the end here by just getting you to think a little bit differently, maybe about implementation or with sort of a different lens. And so this actually comes from a 2002 discussion paper that was on the future of healthcare in Canada. And essentially, it talks about simple problems, complicated problems, and complex problems. So you can see here, a simple problem is following a recipe. And so Janet, I liked your recipe analogy, and I'm going to push it further. A complicated problem is sending a rocket to the moon, and a complex problem is raising a child. And we know from a lot of research that has observed what health systems, like health services and health systems, that healthcare systems are really our complex systems, our complex adaptive systems. But what we do in healthcare often is we sort of describe complex problems as complicated problems. And so we put in place solutions that are often linked to rational planning approaches. And this really does get back to, again, it's a socio-technical sort of environment, I think, right? There's social components to where we work and the technical components. But you can see here that, you know, that many of the problems that we have in healthcare, and I mean, I talk about problems because when we implement things, I think we're trying to close a gap or address some sort of an issue or a problem that we're having, is often like raising a child. And so I think that this sort of helps me to think about it. So I'm an implementation scientist. I use implementation science theories and frameworks in my work, and do, follow sort of a lot of the process that Janet had talked about before. But I think in terms of implementing, and in terms of my own work, but also sort of implementing the real world, I find it very useful to also have a lens of sort of complexity or systems thinking, where I sort of know that, you know, again, you can see it here, but I mean, expertise contributes, but it's not always necessary or sufficient to assure success. Every child is unique and must be understood as an individual. From an implementation science perspective, you know, every context is unique, every setting is unique, and we need to understand that setting itself as sort of as being different than others. I think that, again, I like the raising one child provides experience. So, you know, I come in with the implementation experience, but again, not an assurance of success, as I showed you earlier. And I think uncertainty of outcome remains. And so I think, you know, it's important to understand that if something doesn't turn out as you hoped it did, you know, and you didn't change, well, that's because we live in, or we work within this really complex system. So I do find this really, really helpful to take on a lens of sort of complexity, or to view healthcare systems like this, particularly when I'm working with teams in the system and we're trying to sort of come up with a plan and implement change. And I think it helps me in some ways, you know, think about how do we build enabling environments now? How do we build enabling context and support people as they sort of interact with each other, and as they interact with the new practice or the technology or whatever it is, right? Because at the end of the day, you know, it's staff for the most part who implement change, and they do it often very creatively. They do it, they adapt things. You know, they experiment with the new practice. They, you know, they worry about it. They develop feelings about it. They, you know, they try to redesign things and so on. And so So I think that it's really helpful to sort of keep that lens on and to sort of think about how we can just build the environments that are more conducive to change. And this is my last point, which is interesting because it was also said differently, but was, I think, Janet's point. So it aligns really well. This is from a guy, an implementation scientist out of the US, Dean Fixon. And I like the way he said this. It doesn't matter how good the innovation is. It doesn't matter how much has been invested. If we don't have the implementation savvy, we're going to get the crummy outcomes that we have seen decade after decade. So that's it. I will stop there. Thank you very much.
Thank you so much, Robin, for that presentation. And those analogies were not planned side by side, so I loved how well they fit in together. We just give a moment here. We're going to go on. We have quite a good chunk of time if you're able to stay on for the Q&A. We're going to have Janet and Robin both answer some questions for you. And the way that we're going to do this is you have two different ways. So either you can type your question in the chat box and I will ask it for you. Or you can ask it out loud by just saying your name in the chat box and then I will call on you. So we kind of stay in order here. So I want to actually just jump back to Julianne's question that she may have got some answers from Robin's presentation here. Do most implementation frameworks allow for integrated knowledge translation? Either Janet or Robin, you can start on this one.
Okay, so maybe I'll start on this one. And Robin, you can jump in. And there are other people who may also want to contribute their ideas and thoughts. But this is a great question. And I see integrated knowledge translation as a model or an approach, if you will, for doing knowledge translation research. And so it is a way of co-producing with your knowledge user partners. And so as Robin pointed out in her work, and as I pointed out in my work, this idea of co-designing interventions, but also having members of the knowledge user team, such as in my context, nursing and physician providers who work in the emergency department, and patients and parents who use discharge communication tools on my research team. And so I described using implementation frameworks, but how I use them is through an integrated knowledge translation lens or approach. So I would say yes, most implementation frameworks do allow for integrated knowledge translation, which I think I see as a way of doing research. I don't know if you want to add anything to that.
My answer was going to be yes, in the sense that, I mean, was absolutely, they all allow, because I see it as an approach as well. And I couldn't imagine, to be honest, in most of my work, but I mean, in terms of implementation, like not having other folks around the table. And by other folks, I mean, whether it's clinicians, healthcare decision makers, patient partners, members of the public, because I think it's sort of really important when we're trying to figure out context, right? Like when we're trying to figure out these things, I think, you know, it's really important to have sort of an integrated knowledge translation approach. Yeah. I
agree 100%. It's almost like you're blind if you don't have that lens helping you understand the problem and then identifying potential solutions.
Yeah, exactly.
Thank you. And if you want to learn a bit more about integrated knowledge translation, a little plug, but our last webinar series was on knowledge exchange, and Dr. Christine Cassidy talked quite a bit about IKT. Next up, we have Michelle. You can turn on your mic if you would like to ask a question.
Yeah, sure. So my name is Michelle Halliwell, and I am the manager of the policy office with Nova Scotia Health. And I feel like I probably have a series of questions, and most of them will have to be taken offline. But one thing that really resonated with me was about the stakeholder engagement. And one of the challenges that we see in the policy office is getting around to the idea that folks who are developing policy, be it clinical or corporate, are, that policy has to be implemented, right? Has to be implemented, and it's complex. I really appreciated that model. I used to work in quality, and we used the recipe raising a child model quite a bit. It's complex because generally speaking, we're not even particularly thinking of a unit. We're thinking of an entire system. So how are we going to do this? And we in our office, we're not the implementation experts, but we need to support people to do it. And I guess what I'm asking for is, how do I help them? Because they do not have time to study things. They do not have time to do research. They barely have time to, policy work is off the side of their desk. And then we're saying, well, you got to have an implementation plan for that policy, baby. And yes, anyway, and there has to be engagement. And let me tell you, stakeholder engagement, I can feel them gripping the sides of their desk as we're saying this to them. Yeah. So I'm just wondering if there are some accessible support tools, something that we can or someone else we can hand them off to say, look, you need to go talk to this person because you need help here. Because you're trying to tell 23,000 people how to march left. So how are you going to do that? Anyway, I'll shut up now.
I'll chime in with a couple of things. Thanks, Michelle. So first of all, I totally recognize, I think back to some of the initiatives that I've studied that maybe haven't fully done stakeholder engagement. And oftentimes that's sort of, I want to say, out of their control. Like they were given 6 months to do something, and there's timelines associated and there's not enough people anyway to do what needs to be done. So there's all that around it, right? But then, there are risks to not doing that. And one of it is things not being implemented well and people not using the tool or whatever it is. I think you're in a really hard spot, but I do think there are things. I'm going to point to Julia and the MSSU who may have resources that can help your team as well, right? So Julia is the knowledge translation coordinator at the MSSU, and the MSSU is there to support the health system, government, and researchers. And so there are supports available, I would say, through the MSSU. Julie, I'm not trying to make you busier, but there are. And I do think that we're starting to get more of that. Michelle, I don't know how long it's going to take, but as we shift in Nova Scotia Health to sort of a learning health system, and I do know that folks like Gail Tomlin Murphy, who heads, the VP of Research and Innovation and Discovery. I think we're going to have more and more supports in the health system for implementation and to enable teams and to support them in implementation. That's going to take a little bit of time, but I would say right now, my first thought is the MSSU, because there are resources and supports available and tools and.
Yes, thank you, Robin. And I won't take up too much of the time here to explain them all, but Michelle, if you want to get in touch with us, we are essentially a research support unit. So we are here to support the health system, be that the health authority or the government. And we do have expertise in knowledge translation, evidence synthesis, patient engagement on a consultant and a more focused basis. So we can be in touch later. I'm very interested in speaking with you. Janet, I don't know if you had anything else to provide to that, or I'll move on to the next question.
Given the time, I think we'll move on. I don't have anything extra to add other than I echo what Robin said and what you had said in terms of and identify the need that Michelle I spoke about. In particular during COVID, I think it made it extremely obvious that there is a dire need, as we had so many policy changes happen so rapidly that were continuously being downloaded onto frontline managers to implement. And so I think it became obvious that implementation is critically important.
Thank you, Janet. Ryan, if you would like to put on your mic to ask your question.
Yeah, absolutely. Can you guys hear me?
Yeah.
Ryan.
Great. Hi to you both. I always learn so much when I hear from either of you. So thanks again. This was a wonderful presentation, and really excited to hear it continue and what's sort of on the horizon. So that's great. I think my question is a little bit of follow-up to Michelle's, but I think distinct in its own right. I was on a call to the NNE last week about frailty implementation and sort of implementation of tools across standardization of care. And there was a little bit of that humming and hawing from some of the stakeholders involved in that meeting, where there was a sense of an implementation had been tried, it didn't work, therefore the implementation, therefore stop trying to implement and let's move on to the next thing. I was a little disheartened by that because there's, I certainly got the sense that there was no interest in sort of the, okay, why didn't that work? Or we tried something and it didn't work, but no sort of debriefing or evaluation. It just sort of seemed like a one and done approach to this particular area. And I was just wondering if, when it comes to not only having to motivate or enlist or encourage sort of your champions, your providers, your policymakers, middle managers, how do you also maybe navigate people through the perception of something that in previous efforts, something may not have worked, but it may have been an impact or an outcome as a result of poor implementation strategy versus the it truly not being effective? Like, how do you reach that balance, I guess?
So yes, I have come up against that, as I'm sure many people have. And I think it is, you know, there have been times, I think that sometimes folks in the system get a bit burnt out. And there's often like, I mean, I have a number of examples now where I've sort of worked with teams or tried to engage sort of maybe frontline folks. And it's like, why are we doing this again? This is the fourth time and nothing ever worked, right? I don't know what exactly other than trying to demonstrate that. I mean, you can always go for trying to demonstrate that, you know, you're learning from, oh, thanks, Ryan. You're learning from what happened previously, right? And you're, you know, and you have made small wins, or you have, so in the example that I gave around the TRIC grant, you know, we learn from that, and there's a number of things we put into place, and we let people know we learned from it, right? And there's a number of things we've put in place right now around sort of, it's become a bigger program within NS Health, but around sort of that the lessons learned that were directly influenced, including the engagement of middle managers, and they need to have a formal role in that work. I don't know if I have a really good answer other than I think that happen. I've seen that happen a lot. People just get tired. This is the fourth time we're trying to do this. Let's just move on. I don't know. I guess in some ways I work with people that I know fairly well, that I've developed a relationship with over the years. So I keep trying to nudge them forward, but yeah.
I mean, if I could jump in and say that I think one of the things that we haven't done well, Ryan, or consistently, is to evaluate the process. And so that, as some of you might know, that's collecting data all along. So that's, you know, identifying in advance. So what are the things that would mark success for us? And I don't mean success in terms of an end outcome, but the fact that the process has worked well. So I think that, you know, it needs to become part of our practice, that we are gathering evaluation data all along so that we don't make the same mistakes again, over and over and over again. But we're collecting this process data to identify what didn't work. I mean, to me, that's the most interesting part of implementation science is understanding, well, why didn't it work? And it's from that and collecting that data, then using that data to inform the next iteration. I think that's vitally important, that we need to stamp that into our practice, that we are consistently capturing process data.
Great, thanks to you both.
Thanks, Ryan. Gail's next question, just written out here, is Robin, you said that your evaluation approach to your implementation study of dementia care in acute care was theory-based. What theory did you use for that one? Or probably what theories?
Yeah, no, for the evaluation part, I use REAIM. Janet talked about REAIM. REAIM helps me structure thinking about evaluation. It's fairly simple to use in that sense. It just allows you to think about what it is you want to study. And I also sort of integrate proctors, like when I'm studying implementation and process, just like Janet said, Enola Proctor in the US has sort of a really good paper on implementation outcomes and what it is that you would study. So.
Great. I'm just going to give a moment if anybody else has a question. We probably have time for one more. Again, you can write your name in the chat box or you can write your question.
Can I just put one thing out there? I thought about this while Janet was talking and I forgot to say it.
Yeah.
For anyone that does, so both Janet and I do a lot of work in clinical settings, right? And you can see that from our talk. But for anybody that's interested in this and does more like population health work, I was involved a number of years ago on a paper that the lead author was Jessie Lee McIsaac, so many of you would know her. So if you sort of Googled, implementation science frameworks, McIsaac and Urquhart, you would probably find it, or get in contact with me and I can send it to you. But it was a paper essentially looking at many of the implementation science frameworks Janet just talked about and how they could be applied to population health interventions. So for those of you who do pop health, it might be an interesting read.
I wanted to also share that I have a list of references or reference material. If anybody's interested and want it, you can reach out to Julia and I'm happy for Julia to share it.
Yeah, and I actually wanted to mention that Rob and Janet and I were all working last year on compiling quite a fair bit of resources on kind of the main implementation frameworks that we use here, as well as highlighting different papers in Nova Scotia. So MSSU is actually in kind of the middle of redesigning its website, and all that information will be up in the next few months. But if you are ever interested, one of the biggest questions we kind of get is where do you even go to start looking at these resources and how to pick a framework that Janet talked a bit about. So we kind of have a lot of that background information that we are happy to share. Just send us a message at any time. Great. Well, I am going to close it off now. I want to give a big thank you to Janet and Robin for taking the time today to present to us, as well as everybody else who came during their lunch and stayed. I know an hour and a half can be a lot to dedicate to this type of work and to learning, but it is so appreciative. And to hold the date for March 18th, that will be our next Keeping Up with KT session, and that one will be on the science and practice of communication. So a little bit different than the implementation today. So please hold that date. Promotion will be out soon. And again, if you have any further questions, you can get in touch with me. Thank you guys all so much.
Have a good day.
Bye.
Bye-bye.